Hi, everyone. Welcome to our webinar today on integrated psychological care services. Just to start with, my name is Milena Gandy. I'm a clinical psychologist here, in Sydney, Australia, here for me. In terms of my conflicts, I'm the co-chair, along with Dr. Heidi Munger Clary, of the Integrated Mental Health Care Pathways Task Force of the ILAE Psychiatry Commission, and just some disclosures regarding some travel reimbursement to attend IEC last year. I also do research in psychological care models in neurology, including in epilepsy, and that's why we're all here today. So just some background information for today's webinar. As many of us know, mental health difficulties are quite common in people with epilepsy, particularly depression and anxiety. So we know about 1 in 3 people with epilepsy are at risk of having these significant mental health difficulties over their lifetime. And this is really important because poor mental health predicts many poor outcomes for people with epilepsy, including poorer response to anti-seizure medications and surgery, and it really impacts quality of life. So mental health and poor mental health can impact quality of life even more so than for some people than seizures themselves. And because of this, for many years now, there's been leading neurology advocacy groups, including the ILAE Psychiatry Commission, that's really advocated for mental health screening, referral, and management within epilepsy care settings, so patients are properly managed for their mental health. However, unfortunately, this is not always achieved in clinical reality, given the complexities of health systems and competing demands. So part of today's webinar and some of our other work with the Integrated Mental Health Care's Task Force has been thinking about how can we improve this? How can we move the field forward and help people with this implementation gap? Here are some of my colleagues on the Integrated Care Pathways Task Force, and we'll be hearing from some people today. And we've been missioned with trying to improve integrating mental health care within seizure care settings. What does that mean? So we've got a working definition at the moment, and this involves any attempt to fully or partially blend mental health services within seizure care services. So this can be to kind of a point of, it can be a spectrum where it might just be asking patients about their mental health, screening mental health, referring them to mental health management, all the way to embedding mental health specialists within seizure care settings. And the rationale for this is by better treating mental and physical needs of people with seizures, we'll be able to better care for our patients and have better outcomes and satisfaction, because mental health is common, disabling, and costly. And this is really well aligned with IGAP, the World Health Organization's recent intersectoral global action plan for epilepsy, as well as other neurological disorders more broadly. And they've had targets to improve integrated care within neurology, so it's not so fragmented, and also to have an emphasis on helping patients with their psychosocial well-being and quality of life, of which mental health forms such a core component. So one thing that we published last year as a Psychiatry Commission, a few members, was a special report that focused specifically on psychological care models. And we described 8 models, leading models from around the world that are already established, as a way of sharing, how they've implemented things, to share kind of knowledge, to talk about the core operations, how they work, implementation factors like barriers and facilitators, and outcomes, the clinical and cost effectiveness of these different models. And we distilled a lot of this information from these services to come up with some guiding principles to help with the establishment and maintenance of psychological care models more broadly. And today we'll be hearing from 3 of the service leaders that contributed to that special report. 2 services in pediatric settings and 1 within adult setting. And this will involve Dr. Kirsten Verity from Scotland, Professor Avani from the USA, and Professor Markus Reuber from the UK. And I'm really excited about having these speakers here today, and I hope hearing from their excellent services is going to be of value to everyone tuning in. Thank you.
Hi, thanks very much to the ILAE for inviting me. My name's Kirsten Verity. I'm a clinical neuropsychologist in Edinburgh's Royal Hospital for Children and Young People. And I want to spend a little bit of time talking you through our PAVES work that we're doing, which is Psychology Adding Value Epilepsy Screening. So this is a mental health screening program, which we run on an ongoing basis, business as usual, in our epilepsy clinics in the hospital. So PAVES sort of first came into being in 2016, funded by the Edinburgh Children's Hospital charity. And basically it is a project which has now gone on to be funded by child and adolescent mental health services, and that's been for the past 2 years. So it's a very pragmatic way of looking at how we might assess and meet some of the mental health needs that we see coming into the epilepsy clinics in children and young people with epilepsy. So this is a psychology-led project or model, if you like, and it's really targeting low to moderate intensity mental health presentations or meeting mental health needs at a low to moderate level. Basically, what it is it comprises of a screening tool, which is an electronic web-based strengths and difficulties questionnaire, plus some free text and an algorithm that allows it to be calculated then and there. And on the back of the scoring on the strengths and difficulties questionnaire, there'll be traffic lights generated in a PDF with all the results of the screening tool sent to the consultant neurologist or pediatrician or epilepsy specialist nurse who's leading the clinic. So this traffic light will then help the neurologist or other clinician, non-psychology clinician, navigate a discussion around mental health needs, because we all know that these discussions occur in clinics, but this is in order to allow clinicians to be able to address and identify these a wee bit further in the clinic. And on the back of that, we have stepped, ratified intervention options that can be made available to the child or the young person and their family. So basically what that allows is the neurologists in our clinics would access psychological intervention at a low to moderate level and access these options in real time in the clinic with the child and the young person or the family sitting in the clinic. So from a neurologist point of view, it's quotes like having a psychologist in your clinic desk drawer. So it's like having a psychologist there guiding the conversation and helping you decide what to do next. So the way that we do this practically is that the child and young person is sent the appointment letter with a QR code on it. This QR code accesses our website with the PAVES questionnaire, which is the strengths and difficulties questionnaire plus free text areas. The families complete this questionnaire online, theoretically before the clinic, sometimes in the waiting room while they're waiting to go into clinic. And the minute they click submit, when they've completed the questionnaire, and if the child's the right age, they complete a questionnaire too, sent in immediately into the inbox of the clinician, who can then access a PDF, which will have your traffic lights and the detail of any concerns. So they can then discuss this with the family in the appointment. Any significant concerns about mental health would be triaged with our PAVES clinicians. So we do have some psychology time available post-clinic or even in the clinic sometimes to discuss any significant concerns. But most of the time now, the clinician that can then identify the needs and the potential resources available. And the resources that we make available to these children and young people will either be generic mental health resources that are available and ratified by our psychology services, such as community resources or self-help material, or they might be epilepsy-specific stepped care interventions like referral to Epilepsy Scotland, a third sector organisation, or specific resources for children and young people with epilepsy, like we do a group, psychosocial group, which is the PI group, which is Psychosocial Interventions in Epilepsy, developed by Professor Liam Doris in Glasgow. And we also have our parenting intervention, which is run along with a third sector organisation, Epilepsy Scotland, which we would deliver to the parents of children or young people with epilepsy. So the prescription, if you like, is done in the clinic, and then the families go home with the prescribed mental health supports that have been suggested by their clinician. And then next time they come into the clinic, they go through the process again. So it allows us to have a look at how they're actually progressing and keeping assessing them. It's not a one-off. We keep assessing them as they come in. So you can see in the corner there, we've got a little pyramid that basically shows you the different interventions that we use, from the group work at the very top down to signposting to generic community resources for mental health, and communication with the school with consent. Okay, next slide. So we've been doing this now since 2016. We have published the pilot study of the outcomes of the initial PAVES. And what this shows basically, and I've got a reference in the next slide, what this shows is a cost-benefit analysis is showing a very, very effective intervention, but essentially the requirement to spend, if you like, to save money. So what we found is by reducing referrals to child and adolescent mental health through using PAVES by 62% in the pilot, we have an independent health economy analysis to demonstrate this is an effective thing to do in terms of the reduction in time in referrals to CAMS. We've also seen a reduction in time to treatment. So we can see that we're having 11 weeks wait until treatment, as opposed to for children and young people going into CAMS, it can be months, and it has been over 12 months at times. And we've also spoken to both the children, the families, and the consultants and epilepsy specialist nurses, and finding that this method of intervention has been very well received, and people are very satisfied with this as being a way of addressing some of those lower level mental health needs. So PAVES is essentially, if you like, a kind of blueprint or service model for a way of screening for mental health presentations in clinic, and allowing access to stepped interventions which have been mapped out and ratified by psychology services. And then this is also supported by psychology services to ensure that we have governance to ensure safety and managing all risk. Essentially, this fulfills the mental health need that we know, or some of the mental health needs that we know that this population have in our area in Lothian. It is psychology led and it is psychology managed, but actually it's highly collaborative. And obviously, you know, my colleagues in neurology have been essential, and the whole project was a collaborative venture, if you like, between ourselves and neurology. Despite the fact that psychology led, it's very much a collaboration, and it's not something that psychology can just do to a system. We have to do it together with neurology or the pediatricians or the consultants who are interested and want to participate. So it builds the capacity for the medical system around the child or young person to meet the mental health needs of the young person or the child in a safe and quick manner. And it has been very well received, in that we actually have got NHS England have used PAVES as an exemplar in finding funding through the Children and Young People's Transitional Services. And actually they're using PAVES as a blueprint to roll out models similar to PAVES throughout England. Other Scottish health boards are also interested in using PAVES, and we've actually started within our hospital to use it in another paediatric population, which is the diabetes population, because we know that's also a vulnerable population. And actually, this is the sort of model that could potentially be used much more widely. So it's not necessarily epilepsy specific, but it's evolved within that area because of the vulnerabilities of the population. So the final slide. So yes, basically this is the, if you're interested, the pilot study from Epilepsy and Behaviour, and also a reference to the Strengths and Difficulties questionnaire, which is the questionnaire on which the PAVE screening is based. And we could give you access to the health economics analysis if that would be useful. I believe that you're going to have an email if you don't want to, if you want to have specific information.
Hi, everyone. I hope you can see my screen. Is it working?
Yes.
Okay, thank you. I'm Avani Modi, and I am a clinical pediatric psychologist at Cincinnati Children's Hospital Medical Center in the US, and I am very excited to be here to talk about our psychosocial services in epilepsy. And it's great that I get to build on Dr. Verity's presentation. She did cover quite a few things that are very similar in the US. These are my disclosures. I do have NIH funding for research grants. I serve as the editor for the Journal of Pediatric Psychology, and I have royalties from a book that I published a few years ago. So to start out, I'll give a little bit of a backstory on why we decided to develop an epilepsy psychosocial service that is integrated in our medical clinics. When I was a postdoctoral fellow, I decided that I wanted to go into the field of epilepsy, and to do that, I wanted to be in epilepsy clinics and understand the needs of the children and families that we were seeing. But I had come from a background of actually working in pulmonary diseases. And what I was shocked to see is that we didn't have proactive services for kids with epilepsy compared to some of the other diseases I had worked in, like cystic fibrosis and asthma and even diabetes. And so what I found was that most of our services were really focused on neuropsychology testing, but that the day-to-day management of epilepsy and the struggles that some of our kids faced weren't really being addressed in any systematic way. And so I began to shadow multiple clinics and try to figure out ways that we could determine a psychosocial service that would work for our patients and families, as well as our medical team, to really be integrated. So in 2009, I started to bring residents into the clinics with me to figure out a model of care that would be most effective. And first, we started in new diagnosis clinics where our epilepsy physicians would see kids with single seizure, sometimes 2 seizures. And what we found is that sometimes we were just waiting in the clinic, and if kids weren't diagnosed, that wasn't a very effective use of our time. And so we quickly pivoted into going into follow-up visits for the kids, which actually was quite fruitful because these were all kids who were diagnosed with epilepsy. And what we learned through that is that we wanted to do a very proactive approach to caring for kids through screening, brief interventions, and triage as needed. So in 2011, we hired a full-time psychologist to cover many clinics. And then by 2015, the hospital came up with a strategic plan that really was asking for interdisciplinary care and teams across the hospital. And so we were fortunate enough to hire on 2 additional psychologists to help us with the service, as we had many, many clinics to cover for the Comprehensive Epilepsy Center. And so the way the service works is that in our pediatric model for epilepsy clinics, kids are diagnosed typically at a new visit clinic, and then they are seen at a 1-month follow-up visit after starting medicine, and then every 3 months thereafter. We became integrated at that 1-month follow-up visit, as well as subsequent follow-up visits. And what we would do at that 1-month follow-up visit is review screening instruments that they had completed, which I'll talk about in a minute, and then determine if the family was a higher needs family or a lower needs family. And so low needs families were children who were actually adjusting pretty well to the diagnosis, doing well with their medications, not exhibiting any symptoms of anxiety, depression, or adjustment. And we would discuss with the family a more routine screening approach with them every 6 months so that we could continue to follow them. And really our goal was to introduce our services so that if needs became clear later down the road, they had met us and the stigma of seeing a psychologist wasn't as great. For kids who were screening positive on some of our instruments, or for families that were asking for more help, we considered them high needs. And through this, they were seen every 3 months in parallel with their medical visit, where we would continue to provide resources and or cognitive behavioral strategies to the family, depending on the issue at hand. And then if needed, we would triage them for developmental or neuropsychological testing and or more weekly outpatient mental and behavioral health services. And so what this really allowed us to do is use resources more wisely as far as our outpatient mental health services, and ensure in a very proactive way that kids were getting the services that they need. So here's just a slide that shows some of our routine initial screening measures. When kids are diagnosed in our clinic, they are, from the medical side, often do labs. And so we would explain that we wanted to do the equivalent of labs for psychosocial screening, and we would provide the BASC-2 at the time when we started the service, now the BASC-3. And what this would allow us to do is to understand the functioning of the child before starting medication. So we would have many kids sometimes where behavior became an issue after starting medication, and families couldn't quite remember, it was my child having behavioral issues before, are these being exacerbated? Is this a new symptom? And so this really helped us understand where kids start before they're started on medications. And we also gave a routine questionnaire around the PEDS-QL, which helped us understand quality of life of the children to see if those aspects of quality of life were changing over time too, and then to also try to understand medication side effects. And then depending on the low or high needs, sometimes we would give additional screening instruments around ADHD, depression, anxiety, and behavior. In the clinical setting, if kids were getting strategies and or treatments, brief treatments, we would be providing cognitive behavioral approaches. Sometimes we would help families with sleep hygiene, pill swallowing, behavior management at a basic level, and really help them proactively and provide anticipatory guidance around what they might see over the course of the epilepsy diagnosis. And then, as I mentioned, we would do referrals for outpatient therapy or triaging for testing as needed. To get this service started was a little bit of a Herculean effort because we did not have a lot of great models for integrated care at our hospital at the time that were new. And so I just wanted to briefly review some of the barriers that we experienced and then some of the facilitators that really helped us launch the service. Obviously, there was a little bit of initial reluctance to start something completely new in neurology, and it was going to be a change in standard of care. We weren't quite sure what the cost would be for our service. This is fully funded by billing from the psychologist, and so it was not supported through other mechanisms like grants. And we didn't know what reimbursement would look like initially when we started. There was also logistical issues related to clinic flow and space, which I'm sure all of you are aware of. And then how we would schedule the kids and do dynamic scheduling when our psychology schedule was really mirroring the medical clinic schedule. And then how we defined our productivity metrics. What we found was most helpful was that, as Dr. Verity mentioned, partnering with our neurology team was critical to the success of this. And so we did a lot of presentations to the team to help them understand the types of services we could provide. We had a lot of communication once we started, so they could see the pros and cons of what we were doing. The medical team was very much reinforcing the need for the services, including sending letters to families. When we first initiated this, we weren't sure what the uptake would be, and the uptake of seeing psychology within the medical clinic was about 80%, which was a lot higher than we anticipated, which really showed us that families wanted our services, needed our services. And what we heard from our medical partners was that it took the burden off of them to address psychosocial issues when they really wanted to focus on the medical side. And so it really was a great partnership in what we built. And then obviously technology, when we can figure out ways to make our medical records work for us, can facilitate things going a lot smoother. And so that is how we launched. And I'm really happy to say we have been doing this for quite a while, and patients and families and our providers still find it to be effective. And I hope that what I'm presenting to you has been helpful as you may start your own services. So I'll hand it off to my colleague, Markus.
Thank you very much, Avani. Let me share my screen. Right. So you've heard from two pediatric services. I am going to present our adult service model, starting with a photograph of our hospital. So we're based in an urban center, in a large teaching hospital, but we reach out to a number of satellite hospitals in our region. I don't really have any relevant interest to disclose. So our service is based at Sheffield Teaching Hospital Foundation Trust, and sited in the hospital that you've just seen. We serve an adult population of 1.4 million adults, and we're the only tertiary epilepsy service provider for this population, which means that we have about 10,000 people, adults with epilepsy, that we provide services for. Our services are free to access for NHS patients, and in the United Kingdom, it is very difficult not to be an NHS patient. So pretty much everybody in this country is covered and has access in principle to our service. Our epilepsy psychotherapy service is part of a broader psychological treatment service within the neurology department. And indeed, the majority of treatments we provide is for patients with functional disorders, including dissociative seizures. So for our whole psychotherapy patient population, we have almost 6 whole-time equivalent therapists and some additional trainees. But of the 250 treatments for patients that we provide for functional disorder, we only treat 20 patients with epilepsy per year. So less than 1/10 of the treatments we provide are for patients with epilepsy. Our referrals to our psychotherapy service come exclusively from local neurologists, of whom we have 30 whole-time equivalent neurologists, or from epilepsy nurses. Locally, we have 6 whole-time equivalent epilepsy nurses. So a pool of 36 referrers. We have a screening procedure, which is shown on the right side of my slide. So this just goes through the eligibility criteria for patients in our service. So in order to be eligible, patients do need to be from the area to which we provide care. So we check whether their primary care provider is in the area which commission our services. We then check whether they have had an episode of psychotherapy before. Because of the pressure on our service, we have had to decide that we can only offer one treatment, one course of treatment to patients referred to our service. The next question is whether the primary reason for referral is related to epilepsy, or whether it is a more generic problem like a bereavement or or a primary mental health disorder that is only occurring in somebody who also happens to have epilepsy, but not directly related to their epilepsy, in which case patients would be signposted to other services. Then we check whether a patient have a major psychiatric diagnosis with enduring complex mental health difficulties. These patients are not suitable for our service because we essentially provide a hospital-based outpatient service. We cannot provide community outreach, and patients with more complex mental health disorders that could benefit from psychological treatments need to obtain such treatments from the community mental health services, which can reach out into the community and have staff on the ground. We do exclude patients with alcohol and substance dependence, although we do treat people who use some substances, but not if they're alcohol or substance dependent, in which case, again, we would signpost them to other services first. And the reason being that our psychotherapy service demands a degree of interaction, and patients need to be reasonably stable and motivated to do the work that will help them to get better. A bit like physiotherapy patients. They can't just turn up for their sessions. They need to engage and work on their problem at home. We also defer treatment when patients have had a suicide attempt over the last year for the same reasons I've mentioned before. We don't have outreach services in the community, and we would not be able to provide safe treatment for these patients. And also our psychotherapy requires a degree of emotional stability for patients to be able to optimally benefit from treatment. We then ask referrers to check whether patients are motivated and able to engage in psychotherapy. So that many times in life when people who may have a problem that could in principle be treated with psychotherapy are just not in the right spot, or they're physically unable to come for psychotherapy, or they have comorbidities that interfere with the regular attendance with psychotherapy, which would be key for the sort of improvement that can be achieved in principle. So this point does require some understanding of psychotherapy amongst the referrers, which we've had to grow over time. And if all these conditions are met, we want our referrers to refer patients without any further formal assessment, so we don't use questionnaires or anything before referral. We do ask referrers, however, to write to us, provide the reason for the referral, and be clear that they have explained the referral to the patient. So we do not want patients to be referred without a clear explanation of what they can expect. Next slide. Right. Sorry, my slide is not moving. There we go. Once patients have been referred, we initially screen the referral letter to ensure that it contains the information we require, and then send patients a batch of questionnaires. These are anxiety and depression questionnaires and a quality of life questionnaire. This questionnaire has two functions. One, to tell us a little about the patient. Secondly, to allow us to document the effectiveness of treatment by sending patients another questionnaire at the end of treatment. And thirdly, also as a test. Before we introduced the questionnaires, we had many patients who were referred, but then didn't turn up for their first session, perhaps because they hadn't been informed properly about what psychotherapy involved, or because they weren't on the right spot, or because they lacked a motivation to engage in psychotherapy. So we do use this questionnaire as a bit of a test of people's motivation. Once the questionnaire has been received, we look at it. It contains risk items, and we prioritize and consider patients' treatment needs. We also check whether patients have any special needs, for instance, whether they need an interpreter or extra time, or have transport issues. And once this has been cleared, we arrange a screening assessment, which usually happens between 1 and 3 months after the moment of referral. This would be a one-to-one meeting with one of our psychotherapists, at the end of which a treatment plan is made, which is shared with the patient and also the referrer and their primary care provider. This letter will include some self-help guidance, but also plans, if suitable, for a course of treatment. And we offer up to 20 sessions of one-to-one psychotherapy, occasionally more after discussion in the team and with supervisors and sometimes the referrer. We may, however, if patients are unsuitable for our psychotherapy, provide signposting to other services that are more appropriate. At the end of a treatment, we write a discharge letter that has been discussed and agreed with the patient, and that is again shared with the primary care provider and also the referrer. And finally, we then send patients another batch of questionnaires, the same ones that we've used at entry to our therapy program, so that we're in a position to demonstrate the effectiveness of our treatment, something that has been very important in the development and growth of our service, because we were able to, better than other service providers, to demonstrate that money spent on our service is money well spent. This slide is in tiny print. I apologize for this, but I'll talk you through it. So this is our first effort to demonstrate the outcome of our therapy. This is from a paper published in Epilepsy and Behavior. You can see the reference at the bottom there. So the score at T0 represents the questionnaire scores at the start of therapy or before the start of therapy. These are our screening questionnaires. The score at T1 is the score at the end of treatment, and 60 consecutive patients responded to our request to complete these scores. The score at T2 is 6 months after the end of treatment. Unfortunately, we've lost some respondents there, but still 38 patients responded and filled in our questionnaires again. The questionnaires we used at this time were the SF-12, so a health-related quality of life questionnaire, providing you with a mental health and physical health summary. You can see that there was a significant improvement in the mental health summary from the T0 point to the T1 point. And then there was no significant change between T1 and T2. So patients improved during the course of a treatment from a mean level of 25 to a mean level of 38. So the higher the score, the greater the mental health quality of life. And then it did fall a little over the 6 months thereafter to 34, but not nearly back to the starting level. So that suggests that psychotherapy improved quality of life and that the effects were sustained for at least 6 months thereafter. At this point, we also used the work and social adjustment scale. And again, this showed significant improvement between T0 and T1, and then no deterioration over follow-up. We used the GAD-7 general anxiety questionnaire, the NIDI, the epilepsy and depression scale, and the Rosenberg's self-esteem scale. All of these showed the same pattern, an improvement during the course of psychotherapy that was sustained for 6 months after the end of psychotherapy. So what have we learned as we have developed our psychotherapy service, which is now over 15 years old? One thing that makes our service special is the close collaboration between psychotherapy and the medical epilepsy specialists. One reason why we established our service was that our patients had difficulty accessing generic psychotherapy services. Sometimes they were excluded because they had seizures, or they dropped out, or psychotherapy was suspended because they had a seizure in therapy, or psychotherapists said from the start that the venue where they were going to see patients was not suitable for people who might have seizures. So the close collaboration helps overcome these hurdles. And indeed, we have demonstrated in other publications that it's entirely safe to provide psychotherapy for people with epilepsy. And it is very, very rare indeed that medical help is required. But discussions between the psychotherapist and the neurologist do happen regularly and are key. Close links with mental health services are desirable. This is, of course, unfortunately, something that we have not achieved to the extent that we want. So we do have problems signposting people to appropriate services. but that's mainly because mental health services are in a fairly deep crisis in the United Kingdom and forever changing entry criteria or reducing access to services. It is important that other local psychological treatment providers understand what services we provide to ensure that patients see the most appropriate therapists. It is also important to signpost patients to other services when they could benefit more from other services than the specialist epilepsy services. Otherwise, it is easy to get overwhelmed with the psychological needs of patients we happen to see because they have epilepsy, although their psychological needs are not directly related to epilepsy. I told you that we have provided 20 therapies per year for people with epilepsy. So that's a very low number, given that we have a population of 10,000 people with epilepsy who we serve. So very many patients have actually been assessed and then signposted to other services. This implies that you need very clear referral guidelines and also discharge policies. So we have this 20-session upper limit, which means that you cannot provide long-term therapies to those people who might need it. We do see people who might need long-term therapies, but in those cases, we have to confine our treatment aims to things that we could tackle in the time available. And we then have to look for other service providers for any residual issues that we cannot work on. Or we have to agree with patients to limit our aims in therapy. It is really important that the treatment offer matches the treatment capacity. We've tried to help other regions to set up services, and some of these have folded because they did not have a clear exit criteria, clear selection criteria, and individuals then overwhelmed themselves with by accepting patients for treatments that they simply could not provide. Last but not least, the therapists do need support and supervision, especially when a new service is started. Thank you very much. That was my last slide. So keen now to start a discussion and answer questions.
Thank you, Markus. Oh, okay, let me share the initial slide just to introduce the more moderated panel. So thank you to all the speakers for sharing your so important initiatives. So we're gonna have a moderated panel now for about 10-15 minutes. I'm Gaston Baslet from Brigham and Women's Hospital in Boston, Massachusetts, in the United States. So we have a couple of questions for the speakers who presented on their programs, and also we will try to incorporate questions from the audience. The first question that I have is regarding your, what was the main trigger or motivation to start your program, to start this work?
Maybe I can say something to this. I think it was the perception of need. So I'm a neurologist, not a psychotherapist. So I see patients in my clinic, and we see patients with some, for instance, with seizure phobia. Their seizures have greatly reduced with medication or treatment, but they're still disabled by anxiety about seizures. And it can be very difficult for non-specialist psychotherapists to help understand such patients. So that the need of patients who would not get help elsewhere, that was really what motivated me to help build up our service.
Thank you, Markus.
I think I alluded to this in my talk, but for me, it was the idea that proactive care is better than reactive care. And in kids with epilepsy, we weren't seeing quite a bit of proactive care, and sometimes even the reactive care wasn't there. And so to think about creating a service that helps kids right at diagnosis was just, I think, really important. And as I mentioned, seeing other pediatric populations use that type of a service model, I felt like we were behind in epilepsy. So that's what the trigger was for me.
Thank you.
I think I can answer for our service. I think probably that we have weekly discussions and weekly meetings post clinic, and such a lot of need was always identified, but there was always a feeling of how do we get this in over the threshold, I suppose, as Markus said, in Scotland and England, the threshold to get children and young people looked after by child and adolescent mental health is very, very high. And you also have the risk of diagnostic overshadowing. So it gets complicated when a child is having frequent seizures and is on lots of medication. And, services don't necessarily feel all that confident with those populations. So, it's quite difficult to move them forward. And I think after many, tricky discussions with my colleagues in neurology, we eventually managed to pin down a solution. And I think that the three of the speakers today have all kind of taken a solution which is involving really pinning down the processes and the pathways around how to identify and meet these kinds of difficulties when we're seeing them coming into services. And I think that's probably part of the kind of core, isn't it, is how do we sit down, how do we find the time to sit down with our colleagues and identify what might be useful and have those discussions.
Great, thanks for sharing. The three speakers presented different mechanisms for funding your programs. How were you able to sell your integrated mental health program to the sources that were funding or supporting your program, even if they did not directly fund, but they, supported the infrastructure? What of the needs that you already discussed were highlighted? What were the selling points?
Our model was certainly a leap of faith model because it wasn't funded by any one group. It was a model where we were trying to use our existing billing structures to make the service doable. And so where we had to get a little bit of buy-in initially is my boss had to approve the hiring of the psychologist and take that leap of faith with me. We were lucky because in the US, health and behavior codes had just come online, which allowed us to do the type of billing that's necessary for interdisciplinary care. And then it was really testing the model to see if it was cost effective, and we have data to show that it was. And so then the hospital was very supportive of the model.
I think our story was very similar. So our service started with the misappropriation of money from a nursing budget to pay for a psychotherapist. We then gathered data and were then able to convince our usual healthcare funders that the care we provided was good value for money. We benefit from things that you wouldn't expect to help you in resource-limited settings, in the sense that in the UK, there is a National Institute for Clinical Excellence that assesses whether treatment is worthwhile. So there's a cost per quality of life year gained threshold, which isn't exactly defined, but everybody kind of knows how much money you can spend on a quality of life year gained. And then if you gather quality of life data and can show that you're below that threshold, then you have a reasonable argument for funding of your service. Also, we have guidelines which tell us that we should offer psychological treatment access to people with epilepsy. In more resource-limited settings, you would not have these sorts of arguments, but you'd still have the first steps, or access to the first step, which to find people with enthusiasm to start a service. Psychotherapy doesn't have to be expensive, and many of the gains are made with simple treatments like psychoeducation by people who are capable of providing this. So, a small number of sessions, 1, 2, 3, 4, 5 sessions, can make a difference. So enthusiasm to start it, and then gathering data that may also be possible, and then convincing people who are needed to make the service sustainable.
And I could wade in and say how we first got funded as well, which was actually a slightly different routing. So myself and Dr. Elsa McClellan and Dr. Jay Shetty were the two neurologists who I worked alongside, were particularly passionate about getting some sort of funding for this idea. And we presented it to our hospital charity. So we went to the Board of Trustees one evening and basically, gave them the backstory about mental health in young people, but also gave them a case study and showed them with consent a child having a seizure, and explained, and then subsequently the family explaining the power of the case study, the power of the individual story, I suppose, then meant that they were really happy to give us the kind of initial seed funding to get this up and running. So that's a slightly different routing, but in the end, the health economic analysis then convinced the local services that this was worth investing in, and it's that spend to save kind of model that we've been using then.
And I don't think we should, there are good health economic arguments for providing psychological treatments for people with epilepsy, adults and children. Children, the potential of children with epilepsy to develop well is much greater if they're not disabled by their psychopathology. With adults, their ability to be independent and function independently is going to be much greater if they're not disabled by epilepsy-related anxiety, depression, that can be much more disabling than the seizures themselves in a substantial subgroup of individuals with epilepsy.
Great, no, absolutely, thank you. One question, and we have a question from the audience that I will integrate into this question. I mean, for limited resource countries or limited resource settings, are there any models that you can share that would be fitting? And from your programs, what would be the elements that should be prioritized? If someone has limited resources, what is the one ingredient in your program that you would be using if resources were very limited?
I think psychoeducation is a key step and easy to provide. So by that I mean in the most basic form. I mean an acknowledgement of the mental health problems. So not just asking people with epilepsy about their seizures and shutting down discussion of all other needs, but to enable patients to understand that there's a two-way relationship between epilepsy and psychopathology. The understanding can be a first step to improvement in the right circumstances. If you have, for instance, a supportive family or carers, then that can make a big difference, which costs very little on top of standard epilepsy care, if that just involves asking about seizures.
Can I second that and also expand on that and say that, from, I suppose, two things occur to me. Maybe the first one to expand on that is when you're working with children and young people, it can be immensely helpful with consent to communicate with school that mental health issues may be part of the issue, or that some of what they see in this child may not be to do with seizures, and it may be broader than that, and how to support that. So you could definitely kind of be communicating with the wider systems around the child and young person to provide support. And I wonder whether, also from my point of view, if you're developing anything that starts, if you're asking questions about mental health, it is probably really important as well to ensure that you have a system of risk assessment / triage if you have concerns, because if you get information, you need to know what to do with that information if there's a risk, and how do you manage that risk. Because I think that's often one of the concerns, is if you ask about mental health, what if they say something that I then have to do something with? So you need to have a system in place, I think, to make sure that there's a management of that risk.
I concur with both my colleagues. I don't have anything to add to those answers.
I mean, with the risk, I totally agree. You do need to know what you're doing, but this is, of course, an important reason for people not asking the questions, because they think, oh well, if I don't ask, if I don't learn stuff that I can't handle. If I ask, I might be opening a can of worms. So it's really quite essential not to let this issue put you off trying to make steps towards providing some basic psychoeducation? In Africa, much epilepsy care is provided by people with a degree of psychiatric training. Health professionals go that work in communities and often actually have a mental health training. So they would be in an excellent position to explain, or should be, the links between epilepsy and mental health needs or problems.
Thank you. I have one last question, and we're running already out of time. So if people can be very, very, very succinct in your answers, that would be great. But what would you say? Just one little phrase in terms of the main challenges that you encountered in setting up your program and putting it into practice. What is the one or two top things that were really challenges for you?
I can quickly comment on that. I think I've been working in this job for 20 years, and there's been a lot of changes in the way that we work as the NHS, and there's a lot of complicated reasons for that. But one of the things that I've noticed is making the environment harder and harder to innovate is the pressures on every minute of your job being planned. And actually a lot of the kind of key points behind being able to make PAVES happen is actually being able to spend a bit of time with my colleagues, having a bit of space out, maybe away from my desk, having a cup of coffee, having a chat, having lunch, having somewhere to go to have lunch. And actually these things can be surprisingly challenging in people's working environments, but without those conversations, I think it's much, much harder to innovate. So I think there's something about providing some sort of space and some sort of downtime, and you can't time schedule a time to innovate and think of a new way of working. It can't go into our job plan. It has to kind of come more naturally, I think. So that would be one of my kind of main things.
Great thought.
I was going to say something similar. I think maintaining enthusiasm is if you're enthusiastic, sufficiently enthusiastic, then this is easily doable. It doesn't cost a lot of money to make a start. And there's actually quite a lot of reward to be got from this patient population. They're more grateful and easier to treat, for instance, than our F&D population. So enthusiasm, and I think at least a minimum of one neurologist and one psychologist or psychotherapist working together and sharing that enthusiasm. I think that's what's required.
And I'll be very quick. I'll just say, the need far outweighs the resources that we have, regardless of where we are. And it's very easy to get overwhelmed by that. But to Markus's point, even if you just start with 2 people to start, that is better than nothing. And so that would be my answer.
Well, thank you. I want to thank the speakers for sharing your models and to be replicated or you be used as an inspiration for other people in other parts of the world to integrate mental health care in epilepsy. Thank you.
I want to thank all of the panelists and speakers. This has been fantastic. You've already heard some excellent parting thoughts, but I'll try to leave you with a couple additional thoughts that the group put together. My name is Dr. Heidi Munger, Clary. I'm an adult neurologist in the US, and I also co-chair the Integrated Mental Health Care Pathways Task Force with Milena Gandy. So Dr. Gandy mentioned IGAP, the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders. And integrated mental health care in epilepsy is a key component of this. It can help achieve better management outcomes. And like you heard today from our speakers, aligning with existing services and programs can be one tool to achieve that goal. And while our program focused on integrated psychological care models, it's important to note that there are also excellent models that incorporate medication management, such as collaborative care. And then I'd like to leave you with 5 key tips that the group came up with together that hopefully that, along with this wonderful discussion that you just heard, will bring you away to your environment inspired to try to start something new. So key points are a neurological champion is really important to help integrate these services in routine care. Screening tools and outcome measures, they're validated and they can help in the practical day-to-day running of these services and help you measure the impact of your service. And the goals and the interventions that you incorporate are going to be very specific to your site and adjusted to the population you serve, the needs there, and the available resources. And make realistic goals for what your environment is. And it can be something small, but it can be achieved if it's realistic for that environment. To create sustainable programs, the treatments offered must match the capacity and funding available, much like we just talked about in the previous point. And then also, if you create a model that has clear guidelines, that can help neurologists be more comfortable on what steps to recommend or take. Again, I want to thank everybody for a wonderful discussion. Hopefully you came away with some good ideas. And if you have some further questions for our service experts, their contact information is below at the end of the slide in the order that they presented. Well, thank you so much for a wonderful program. I hope you have a great rest of the day, everyone.